I don't have a sense of certain psychiatric treatments or medications that need to be avoided. It's more about paying attention to the individual sensitivity.
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos syndromes, dedicated to helping you navigate joint hypermobility and live your best life. Today's guest is Dr. Janet Settle, an integrative psychiatrist. I'm so excited to have this conversation. I think I've shared before that I have lived with anxiety my whole life and also ADHD. And we are learning so much more about how mast cells can play a role in both of these conditions. This is going to be a great conversation that I think so many people are going to benefit from. Dr. Settle is a board-certified integrative psychiatrist with over 30 years of experience blending conventional and holistic approaches to mental health. Disenchanted with the limitations of traditional psychiatry early in her career, she pursued training in 5-element acupuncture and was among the first physicians board-certified by the American Board of Holistic Medicine in 2000. She later completed a fellowship in anti-aging, regenerative, and functional medicine and was board-certified by the American Board of Integrative Medicine in 2016. Her practice focuses on identifying and treating the root causes of chronic medical and psychiatric conditions using functional medicine. Dr. Settle also specializes in trauma treatment, drawing on psychodynamic psychotherapy, EMDR, attachment therapy, and internal family systems, or IFS. She has worked on specialty inpatient trauma units and completed advanced psychotherapy training through the Denver Institute for Psychoanalysis. I am really excited about this conversation. As always, this information is for educational purposes only, and it's not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Well, I'm super excited to be here with Dr. Janet Settle. It's so great to see you. I feel like it's been such a long time.
It has been a long time. Yeah, it's nice to see you too.
Yeah. Well, I'm really excited to chat about this really, really important topic. And what first drew you to study or treat patients with mast cell activation disorders?
As you might expect, it was sort of a long journey. I started my psychiatric practice, my private practice, in the early 90s, and pretty quickly got disillusioned with the tools that I was given in my residency training and just started grasping around at this, that, and the other, and studied acupuncture for a while and took extra psychotherapy training. And then I got into holistic medicine. I got into treating people with supplements and fish oil and 5-HTP. And still, the more I identified as someone who was interested in holistic and integrative methods, the more and more people started coming to me with complex medical problems, sometimes not even psychiatric problems, but often, most often a combination of medical and psychiatric problems that, were not being well addressed by conventional medicine. And so it's like the drumbeat got louder. And I kept searching and learned about doing hormone replacement. And then I got fellowship trained in functional medicine. And then finally started hearing from some of my colleagues about mast cell activation. And then I went to the first mast cell activation meeting I went to was the one that was held here outside of Denver in Broomfield in 2019. And that's when, I sort of thought, okay, now finally it's 2019. Finally have a finger on the pulse of what's maybe really going on. So it took me a long time, but I was motivated by, even before I was interested in holistic medicine, just the number of people who had intractable fatigue. In psychiatry, traditionally, we lump fatigue into depression. So everyone who has depression and low mood, which all people with chronic illness have depression and low mood, would all sort of get assigned a diagnosis of major depressive disorder, which I think may or may not be true, but it certainly is not what addresses the fatigue. And of course, the low mood is because of the oftentimes, because of the daunting task of managing a chronic illness, oftentimes without enough help from the conventional medical establishment. So that's sort of a long answer, but it's been a real journey.
And that's where we first met, was in Broomfield.
Mm-hmm.
And at that time,
Mm-hmm.
I didn't live in Colorado yet. In fact, my husband had wanted to move to Colorado, but I was not so sure. And then I came out for that meeting, and I was like, "Oh wow, this is a beautiful place." I'd been here to ski a couple times, but
Uh-huh.
yeah, I remember meeting you there, and then of course I met you in New York
In
as
New
well
York,
a
yeah.
couple of years
Mm-hmm.
later, a few years later. So, which was great. We had lots of fun conversations there.
Yeah.
Um, how has your understanding of mast cell related psychiatric issues evolved over time?
Well, really from 0 to 60, when I first started learning about mast cell activation, I thought, oh, this is going to give me some tools to help these people with chronic illness and fatigue, for example, with their other symptoms. But I really didn't realize how much it was going to help their mental health symptoms. So
Mm,
I was thinking of it like, oh, well, I can still do my, integrative psychiatry thing, but then I can add on these mast cell strategies. But then it turned out that the mast cell strategies treat a lot of the mental health symptoms. So I wasn't
mm,
expecting that. So that's been a real evolution. And then beyond that, I think my conceptualization of what are these mental health conditions, what is major depression and what is bipolar disorder and what is panic disorder, has fundamentally shifted to the point that I now think some of what we call psychiatric illness, so to speak, is really mast cell activation that's not yet been, acknowledged or put on the map. So it's been
mhm.
pretty drastic change in my conceptualization. Yeah.
Mhm. Yeah, I remember at that meeting when they had a microphone, we could go up and ask questions, and you went
Mhm.
up, and then you said you were a psychiatrist, and, some of the things that you said, I was like, "Wow, that's" I hadn't thought about it that way, and I know there are now some papers that have come out talking about the role of mast cell in, psychiatric conditions, so it's super fascinating, and of course,
Mhm.
we jumped in and immediately started talking about mast cell, and mast cells, but maybe we can just back up a little bit and just explain what mast cells are and what happens when they become overactive or dysregulated.
Right. Mast cells, I describe mast cells as sentry cells. They are in everybody. They're in the skin. They're in all kinds of interfaces where it's the interface between the inside world and the outside world. They're in the lining of the gut, the lining of the bladder, the lining of the lungs, the blood-brain barrier, in the skin, and they're sentry cells. They're kind of primitive in a way because they're kind of binary. They're either calm or else they're like, dumping all their alarm signals, and they're full of hundreds of different inflammatory chemicals and other kinds of alarm signals. The histamine is the one that is sort of a household word, but there's literally hundreds of others that aren't household names and not even in med school. So when these mast cells get triggered, they dump their signal load, and then those signals, travel around locally to the area where the cells are living, but then they also can get in the bloodstream and travel through the rest of the body. And they're alarm alert signals. And what happens in mast cell activation is that the mast cells become more sensitive and they're more easily activated and they're harder to calm down. Mast cells are born in the bone marrow, and then they have a lifespan of months to years. And so the reason that that's important is because sometimes it can take some time. It's a project to try to get a person's mast cells calmed back down again, because once they've gotten kind of overactivated, it's hard to get the genie back in the bottle. Yeah.
Definitely, and we know that so many people go for so many years without being properly evaluated or diagnosed. And how do you normally describe the link between mast cell disorders to psychiatric or neuropsychiatric symptoms?
Well, I think one of the reasons, just a little bit of follow up to what I was just saying, one of the reasons that really isn't on the map yet for conventional medicine, or only in a very limited way, is because we sort of thought that histamine is only about allergies or something like that, that it should only be about allergens. But one of the things that happens because these mast cells are located in so many different parts of the body, if you line up 10 people with mast cell activation syndrome, they'll have 10 different clinical pictures, right? I mean, some people have the gut issue, like an IBS picture. Some people have chronic pain, joint pain, or some people have migraines, or some people have asthma. Some people have, bladder symptoms, interstitial cystitis. Some people have hives and anaphylaxis. So, or some people have a couple of those, but not the rest of them. And so if somebody looks at a laundry list of symptoms, they might think, oh, I don't have all of that, and so, but oftentimes missing from those comprehensive symptom lists are the mental health symptoms and the psychiatric symptoms that it turns out, in my experience, definitely go right along with this. And most often, the histamine and other mast cell mediator types of mental health symptoms are any kind of activation. So panic, anxiety, hypomania, people feeling revved up, racing thoughts, irritability, insomnia, and brain fog, maybe some kinds of things that people think of as being more like ADHD, I think can be related to histamine and mast cell mediators. Well, that's a whole bunch of symptoms that are bread and butter for most psychiatrists, bread and butter kinds of conditions that we treat all the time. One interesting thing, I was always wondering, why is it that we all got nationally and globally fixated on serotonin and never on histamine? Well, it turns out that the stains that allowed scientists to study the tracks and the projections in the brain samples, if you take a postmortem brain and you're studying neurotransmitters, the stains that they had for norepinephrine and dopamine and serotonin came around about 20 years earlier than the stains for histamine. Histamine is such a small molecule. It didn't stain well. They couldn't track it down. And so really all these other things were sort of stained in brains, and they started understanding the way they operate in brains in the 60s, 50s, and 60s, where it really wasn't until the late 70s, early 80s that they could study what was going on about histamine in the brain. And, by then, of course, the 80s is when Prozac came out. The world was already on a gigantic love affair with SSRIs. Nobody was thinking about histamine except allergies. So that also, I think, was sort of a converging circumstance that slowed us down in terms of understanding histamine and its effect on the brain.
That's super interesting because, you don't normally think of things like that. I've never heard that before, but it makes sense what you're saying. So that's really fascinating because I know that, mast cell mediators like histamine, tryptase, cytokines, those things can affect the brain and affect the mood, but we don't normally think of that. Like you said, we normally think of serotonin and dopamine. And how do those mast cell mediators affect the brain and the mood?
Right. There are a couple ways. I mean, the mast cell mediators live right on the surfaces of the brain in the blood-brain barrier. There's some kind of controversy about to what extent do they live inside the brain, completely inside the brain, but they definitely talk back and forth with these chemical mediators, these cytokines and histamine and other activation chemicals with the immune cells of the brain, with the macrophages inside the brain. They're called microglia in the brain, but there's crosstalk back and forth between the mast cells and the microglia. And it looks like the mast cells can sometimes cross the blood-brain barrier and get into the brain, although that's kind of more cutting-edge research. So those chemicals just go in like any other neurotransmitter and activate parts of the brain. Histamine is a neurotransmitter, but people don't think of it as a neurotransmitter. And there are histamine-producing neurons in the brain. They live in the limbic system. There aren't that many of them compared to the other neurotransmitters. Maybe that's one reason that they were discovered later too, but there's a group of histamine-secreting neurons in the limbic system, and they spray their projections all over the entire brain, but it's a relatively small group of neurons. So they act in both ways. Histamine itself can act in a typical synaptic way where it's sending a message across a synapse from one neuron to the next, but it also can diffuse through the brain tissue to have a more localized message, which I suspect is part of what's going on in a panic attack, although I can't prove it.
Interesting. So if someone, given how, again, this is not medical advice for people listening right now, but if someone has a panic attack, given how safe antihistamines are, would that be a reasonable thing to try, knowing that it's not going to take effect within, seconds or a few minutes, but I mean, you could maybe see some benefit in, 15 to 30 minutes, depending on the medication.
Absolutely. I think that I've heard lots of people, and I mean, I think a couple people this week say, "Well, yeah, the this or that medication for anxiety never did anything for me until I tried Benadryl." And Benadryl can be a perfectly good anti-anxiety medication.
Mm.
And Ketotifen, which I'm sure we both prescribe for,
I prescribe it all the time. Yep.
all the time, compounded medication that's a mast cell stabilizer, is great for use as needed for anxiety and panic or in other kinds of anxiety, especially people like the sublingual form when it's compounded into a dissolving tab or a sublingual something. You stick it on your tongue or in your cheek. And that's very popular among my patients for, a PRN for anxiety.
Interesting.
Yeah.
So I usually start people at like 0.5 milligram or 1 milligram. Is
Mhm.
that, would it be a dose like that you would use, or okay?
Yeah, it'd be the same kind
Okay.
of dose. Yeah. Usually I start with 0.5 milligram, so it's in case it's sedating. But usually when people are anxious, they're not very easily sedated. So
Mm-hmm.
yeah.
And I know hydroxyzine also can be used for a similar purpose, right?
Yes, hydroxyzine is super convenient because it comes in the 10 milligram, commercial size in addition to the 25. Sometimes if 25 milligrams is too sedating, I'll have people take 10 milligrams as needed for daytime, anxiety, and that works pretty well. I think the Ketotifen probably works better, but the hydroxyzine is definitely good.
And if cost is a factor, oftentimes then you can get that covered by your insurance, and so
Yeah.
yeah, okay, great.
Yeah, and with Benadryl, of course, you can get children's Benadryl in the liquid, drops, and then you can titrate a smaller dose if the 25 is too much.
Mm-hmm.
Yeah.
Mm-hmm.
Mhm.
And I know Doxepin is available as a liquid, and I've used that before in like low dose. Hydroxyzine, is that available as a liquid also? I feel like maybe it is, but maybe
I
not.
haven't used it. I don't
Okay.
know. Yeah,
Okay.
I don't have. I don't
I'll
know.
have to look into that. I
Yeah.
will look into that so that I can. So, okay, great. What about neuroinflammation and the gut-brain axis and the vagus nerve? What kind of a role do they play?
Absolutely. I think that neuroinflammation is very influential in all of these conditions, and that mast cells are driving neuroinflammation again through that crosstalk with the macrophages. So
Mhm.
it's sort of a two-way street. If you have inflammation for some other reason, right? You have inflammation anywhere in the body because you've had an infection, an accident, an injury, a stressor, even any kind of emotional stress, or dental work. I can't tell you how many people come to me and they say, "I was fine. I was cruising along fine, stable on my meds, and all of a sudden, the last week or two, I'm just anxious. I can't sleep. I can't function." We're going through the list of like, did this happen? Did this happen? Did this happen? And they've had dental work or dental,
Really?
surgery and it really kicks up. That's an inflammatory signal that activates the mast cells. Then the mast cells go back and activate more inflammation, and it turns into, kind of a spiral. I'm very interested in the new information coming out about neuroinflammation. The vagus nerve is a super highway of information going in both directions between the brain and all the organs in the body. But I think 70 or 80% of the information is going from the body to the brain. So anything that happens in your body, whether it's stress, whether it's, again, injury, accident, illness, is sending those signals up the vagus nerve. There are signals of injury, illness, trauma, up to the brain and activating the brain and contributing, I think, to that inflammatory state. Of course, if an inflammatory state is a good thing. If you have to, heal an injury, if you break your arm, you need inflammation, you need your body and your brain to be working together to set up all the conditions for that to heal. But in some people, it seems to turn into a vicious cycle where it's hard to turn that inflammation off. And I think that's what is one of the factors that drives certainly fatigue. I think of fatigue as being a symptom of inflammation, whether it's in the brain or the body. I mean, it's interesting to figure out where to point the treatment, but the brain and the body are, in sync with each other, and one is inflamed, the other at least knows about it if it's not also joining in. The gut-brain axis is also really important. We have as many neurons in the gut as we do in the brain. And so they call the gut the second brain. And, we have all kinds of things in our language that sort of acknowledge this. You get a gut feeling, or I knew it in my gut. So all the neurotransmitters that are working in your brain are also working in your gut. So I think they really mirror each other. Taking care of imbalances, all kinds of root cause conditions and things in the gut is equally important to treating mental health, and part of what I do in the functional medicine, part of my practice. And in that pentad of conditions that we talk about, the mast cell activation, Ehlers-Danlos, POTS and dysautonomia, autoimmunity, and the last one is GI, is SIBO dysmotility type conditions in the gut. So that all of these things are peas in a pod. They all run together. I mean, they all run in a pack together is what I mean. They're all probably not 5 distinct things. They're probably offshoots, of one or a couple things. So
yeah, that makes sense. I was curious. We don't want people to not go to the dentist, of course, which I know you're not advocating. I know you're not advocating that. What do you think about pre-treating before you go to the dentist? Taking some more antihistamines or more mast cell stabilizers or something like that. Is that something that you ever advise people to do?
Absolutely. I do recommend that people who know that they have some mast cell either activation or even sensitivity pre-treat for any known stressor, pre-treat for travel if they're going to, have some rigorous travel schedule or stressful exams or dental work, or, you get exposed to somebody in your household has a cough and your body's going to be fighting that off. I tell people to have a very low threshold for adding on items from their rescue kit. In my thinking, which I'm sure is, common in our professional group, people have kind of a maintenance plan with things that they take regularly, and then they have a rescue kit, which might be doubling up on or adding more, items or more higher doses of things from the rescue kit from the maintenance plan. But yeah, I tell people to have a low threshold for jumping on the rescue remedies at the first sign of trouble. Or if you know about the trouble in advance, that's even better. And I definitely want people to go to the dentist because, untreated dental things are another source of mast cell activation, right?
Yeah, having untreated gum disease or whatever can contribute to inflammation in the body, and is definitely not good. But that's really important to know that. I like the maintenance plan and then the rescue kit. I like those terms. I think that's very clear as compared to, a lot of people talk about flares versus dips. I kind of like the term dips because I feel like flares, I don't know, that term I feel like is whatever works for people, of course. But I think that sometimes the words that we use matter a lot, I guess is what I'm trying to say.
Yeah, I like that word dip. I haven't heard that. That's good.
Yeah.
Uh-huh.
So in terms of psychiatric symptoms or diagnoses that might be mast cell related, you've talked about depression, panic, anxiety, ADHD. What about things like PTSD, mood instability? What about personality disorders? Can those things be mast cell related?
super interesting questions. I mean, definitely mood cycling and mood instability. I think with mast cells, I'm looking at anything that's kind of an intermittent episodic kind of a symptom. So whether it's hives or an attack of IBS or an attack of migraines or an attack of a panic attack or a mood swing in one direction or another, anything that's kind of recurrent but intermittent, I think of those as potential mast cell symptoms. But I do see a lot of mood swings that I find are responsive to mast cell stabilizing strategies and also strategies for reducing neuroinflammation. I haven't thought as clearly about PTSD, but of course, stress is such a clear and tangible trigger for mast cells that it would make sense that that would play a role in PTSD, but I haven't done a systematic analysis of, how many of my patients with PTSD also have mast cell activation. I'll have to think about that. I have thought quite a bit about personality disorders, and I do have a pet theory without too much evidence behind it yet that the state of systemic inflammation and neuroinflammation that people get into and sometimes have to live in really does change a person's how do I want to say this? Coping strategies, maybe styles for living, styles for coping with life. And that, when you're sick, when I'm sick, when anybody is sick, it's a regressive experience. It doesn't pull on the most, mature coping mechanisms and our most advanced level of functioning that we've ever reached in our lives, And so then you could make an argument like, is the way someone's functioning personality-wise with a chronic illness, is that really their personality, or is that really a side effect of their inflammation or the level of pain that they have to live with? I don't know. I think that's going to be a super interesting question for the future.
Yeah, definitely, definitely. And I have one more question before we take a quick break, and this is
Mhm.
kind of a big question. So just
Okay.
how can clinicians distinguish between primary psychiatric disorders and psychiatric symptoms driven by physiologic inflammation or mast cell activation?
That is the
The
zillion
million
dollar.
dollar question.
It is the zillion-dollar question. You can't.
Mhm,
They look the same,
mhm.
and that's the trick. I think the
Yeah.
trick is to look for it. The trick is to test for it. The trick is to have mast cell mediators and histamine on your internal differential when you see someone with that list of really almost any psychiatric symptoms,
Mhm,
and then go ahead and do the investigation, whether it's someone who's going to be positive on lab testing or not, or whether sometimes it's easier because someone will give me the history and will say, oh yeah, I have interstitial cystitis and I have hives and I've had anaphylaxis and I've had this and I've had that. Then it's like, okay, this is starting to come together. This is looking like these may well be psychiatric symptoms of mast cell activation. But the weird thing is sometimes there's none of that,
mhm,
and it's just purely psychiatric symptoms, but it's still mast cell driven,
mhm.
and
Sure.
so then you just have to try. You just have to try and say, well, why don't
Mhm,
you try, the usual things? Why don't you try a little Benadryl? Why don't you try a little whatever, Ketotifen? Why don't you try a little of this or that? Under supervision, of course. So yeah, sometimes it's more obvious, and I think it will be great as mental health providers and psychiatrists start asking some more of those questions about the comorbidities so that they can put that picture together. But
mhm.
just like I might see someone psychiatrically with a certain symptom and I'm like, well, I'm not sure if that's more of a dopamine issue or a serotonin issue. people don't yet think, I wonder if that's a histamine issue, but I think they will. Yeah.
Mhm.
Yeah.
Yeah. Okay. Great. Great. We're going to take a quick break. And when we come back, we are going to talk about treatments for mast cell related psychiatric symptoms. So we will take a quick break and we'll be right back. I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. We are going to jump into treatment in just a minute, but I have a couple of questions before we get into treatment. First, I wanted to ask, are there other medical causes? I know there's other medical causes that can be missed for causing psychiatric symptoms. For example, maybe metal toxicity or something like that. Is there something that we should be aware of because it's rarely discussed?
I'm so glad you asked. There is a long list of things that I hope people will look for. Of course, everyone's knows, I think, that we should check thyroid for any kind of psychiatric conditions. And interestingly, I've found quite a small number of people where the parathyroid was elevated, and that identifying that and then having the parathyroid surgery allowed people to get off of antidepressants entirely, which I thought I didn't learn that well enough in residency. So I'm kind of a stickler for checking both thyroid and parathyroid. And of course, with anxiety, you want to check for an adrenal tumor, pheochromocytoma, but I've never in 30 plus years identified one of those myself. I think yeast overgrowth is something that I think is under recognized and undertreated. And I think with the people taking antibiotics and people taking steroids for this and that, yeast and fungus can really get going in people. And I get some good traction for, I would say, more sort of nonspecific physical and psychiatric symptoms, fatigue and especially brain fog and itching and GI symptoms, bladder symptoms, acne, that kind of picture with sometimes testing for fungal. It's hard to test. It's hard to test for, but there are various ways you can try to test, or sometimes just treating presumptively. If the clinical picture looks convincing enough, I may just give someone a course of some antifungal. In terms of metal toxicity, mercury and candida help each other. They're like little partners in crime. And so when you find ones, you oftentimes will find the other, and they help each other. So I do some metal testing, and I do sometimes prescribe I don't do IV chelation, but some kinds of detox strategies that may help with heavy metals. But usually I'm working on other things first. It's not at the top of the list for me to work on the heavy metal toxicity. I think that parasites are under-recognized and undertreated just because we can't find them very well. They're so darn smart about staying hidden, and everything you try to do to test them comes back negative, and then there's kind of this presumption that we're living in a developed country, we don't have any parasites, but that's just not true. So my thinking is evolving. I haven't landed anywhere. We'll have to talk about this next time. I don't know where I've exactly landed about parasites, but they're on my radar for people who have mystery symptoms, and have tried a whole bunch of things and not gotten relief. I'm like, well, I don't know, let's think about this. I've been reading some of the work of Dr. Simon Yu, and that's been informative. And of course, we were talking about dental. I think I saw on your podcast that you have had a dentist who you interviewed, and did you have a conversation about cavitations and all of that?
I don't think we really went into cavitations.
Mm-hmm.
Not
Well,
to significant, yeah.
yeah, cavities are infections in teeth, and cavitations are the infections in the bone underneath the tooth. And so people can have cavitations. That's like a silent, hidden infection underneath a tooth. Most often, it's like a root canal tooth or a wisdom tooth spot, where a wisdom tooth has been removed, but maybe not completely. Um, so with a root canal, they kill the nerve. That's part of what the root canal is, to say kill the nerve. So it's painless. You don't have any pain, but you have this hidden infection.
Mm.
So again, when people have chronic, mysterious symptoms, I will refer them to get what they have a special CT scan. It's just like one of those panorama kind of x-rays, but instead of an x-ray, it's a CT scan up the roots of the teeth, and you can see the cavitations. And sometimes people have very dramatic results getting those things cleaned out, including depression. I've seen that. I've seen depression really respond to getting the cavitations treated.
That's fascinating. Are there certain things for people specifically with the cavitations, specific things that would make you more suspicious about that?
Hmm. Certainly, like I've seen someone recently who had chronic facial pain, like you see someone who has like what looks like a trigeminal neuralgia or sort of a chronic facial pain. That would make me suspicious. Migraines. But in the case that I was thinking about, where the depression clearly responded, there was none of that as a tip off. So mostly I'm just asking people, like, how many root canals do you have? And so another tip off, of course, is like, oh, I had this crown replaced, and it's still, sort of is achy and hurts 8 years later, or something like that,
Mhm.
or a root canal that they've gone in a couple times to try to redo it, and it's still, the person still has pain. I think that would be a tip off. Yeah.
Mhm, mhm. Okay. Okay. And what other treatments have you found most effective for psychiatric symptoms in patients with MCAS or related conditions like EDS or dysautonomia?
Well, all of the usual mast cell treatments apply and do help with psychiatric symptoms, just like they help with non-psychiatric symptoms of mast cell activation. So the usual antihistamines, the H1 blockers that we talked about, the H2 blockers like Pepcid and Tagamet, Ketotifen. I use low-dose naltrexone quite a bit. The supplements like luteolin, quercetin, nettles, PEA, all those things apply, but those aren't, specifically psychiatric treatments. So then, in terms of psychiatric treatments that I use in this setting, that would probably fall into two different categories. One category would be psychiatric meds that are also have some antihistamine activity. So things like Seroquel or Remeron come to mind. Sure, there are others that I'm not thinking of right now, but and you mentioned Doxepin, um, certainly Benadryl and hydroxyzine. But the other group of medications would be things that reduce neuroinflammation, but they're not essentially antihistamine in nature. So that would be things like lamotrigine, which is Lamictal, or lithium is very anti-neuroinflammatory. And one of my favorites is an SSRI that nobody's heard of called Fluvoxamine. Once upon a time, it had the brand name Luvox, but it's only generic now. It was the last of the whole line of SSRI. So everyone was like, oh, another SSRI, you know. And but it turned out to be a special one. Turned out that the last one was maybe one of the most special ones, but it never got any attention. So fluvoxamine works as an SSRI, but it also is anti-inflammatory at something called the sigma-1 receptor, and throughout the body, not just the brain, but the whole body. And for example, in COVID, when people were hospitalized, they were using fluvoxamine in the hospital as an anti-inflammatory for people who had no psychiatric symptoms whatsoever. And they came out with at least one study showing improved outcomes at the end of the hospitalization from using fluvoxamine for hospitalized COVID patients. So it's very anti-inflammatory. So I really like fluvoxamine. I like it as an antidepressant. It's also pretty good for sleep. It's sedating in low doses. The low dose would be like 25 or 50 milligrams, or maybe anything up to 100. The label says the full dose is 300 milligrams. I don't know that most people really get up to 300 milligrams, but maybe 200. I have some people on 300. But, so the dose range is something like 100 to 300 milligrams at bedtime because it's sedating. I want to back up, though, and say I'm glad this came up because one of the categories of symptoms that is really related to neuroinflammation is obsessive anxiety. And by that, I mean the looping thoughts, the rumination, the intrusive thoughts, where you can't get something out of your mind and you're over and over and over again. Some people have obsessive anxiety and then they also have compulsive behaviors. An obsession is an unwanted intrusive thought, and a compulsion is an unwanted intrusive behavior that's designed to neutralize the thought. So, for someone who has obsessions about cleanliness and then they have a compulsion that's hand washing, or somebody has an obsession about safety and their compulsion is they don't leave the house or don't drive, or, don't drive on the highway or something like that. So some people have that full blown where they have both the obsessions and the compulsion. Some people just have the obsessive anxiety as part of their depression, or even part of their bipolar picture. And this fluvoxamine is really effective. It's FDA approved for OCD, but it also works for regular depression and obsessive anxiety. And I really believe that obsessive anxiety is different from garden variety anxiety. I think it's biochemically different, and that it responds to anti-inflammatory strategies, like the things that we were just talking about, like low-dose naltrexone is an anti-inflammatory strategy that is good for all kinds of symptoms, but obsessive anxiety is one.
That's so interesting. And fluvoxamine, I did prescribe that for a while during COVID. I haven't prescribed it for a long time, but was there somebody in St. Louis, maybe at WashU, that was doing a lot of research around that? I feel like I was reading about that in a lot of different places. So that's super interesting. Is that hard to come off of like a lot of other SSRIs, or is that not as bad?
I haven't thought of it as being particularly bad, but I don't know if I know the answer to that. It's not in my mind as a front runner of trouble with withdrawal. Like Paxil is hard to come off of, and of course, Effexor is the worst, but it's not an SSRI.
I've heard terrible things about that. Yeah, people trying to come off of that. Yeah.
Usually my strategy works pretty well, which is if somebody wants to taper off of whatever they're taking, whether it's an SSRI or it's an SNRI, we switch them over to Prozac, fluoxetine, because that has a long half-life and it's kind of self-tapers. So you just switch over to Prozac, and then we write a 6-month taper, which is pretty simple and straightforward, and it usually works great, where you take it Prozac, you don't have to take it every day because it lasts so long. It's got such a long half-life. So you can take it 7 days a week for a month, and then 6 days a week for a month, and then 5 days a week for a month, and then 4 days a week for a month.
Oh, wow.
On and on down you go. And
Uh-huh.
and it usually is kind of a non-event. So
Mhm.
that's my secret tip about SSRI withdrawal.
I love that because I've had a couple. I'm not a psychiatrist, obviously, but a lot of my patients are on psychiatric medications,
Mhm.
and they'll share with me that they tried to wean off of whatever the medication was. Pick an
Mhm.
SSRI or an SNRI, like you're saying, or even non. These medications that cross the blood-brain barrier, right? Are just a lot more difficult. So that's a great tip. So can you, when you do that, how long do you have to wait after starting the Prozac before you can start? Do you wean the other one, or can you stop it? Or it depends on I'm sure it depends on the medication and a variety of other factors, but
Usually you can cross over pretty.
Mhm,
It's pretty simple. You need to have someone who can help you find the equivalent dose, and then
mhm,
you need to make sure that you've gotten close to the equivalent dose by looking for either side effects of too much or
mhm.
withdrawal symptoms of too little. So you try to dial it in, make sure you're getting the right dose, and then you can go ahead and start taper. So, yeah, I usually change someone over entirely, and there might be I don't know. It sort of depends. You know how people are sometimes are more robust and they're like, oh, yeah, they just roll with anything. You can just change them
Mhm.
over. But some people are more sensitive, and maybe I do it cross taper for 2 or 3 weeks, to get them over from one to
Sure.
the other. Yeah.
Sure. Okay, great.
Yeah.
And, you and I have talked about ketamine on a number of occasions. And I know that, I prescribe ketamine sublingually. I don't normally prescribe it nasally, although I have done that before. What are your thoughts about ketamine?
I most often am sending people for IV ketamine, for the 6 IV treatments for depression, which has been shown in the literature, to really help pull people out of the ditch from a major depressive episode.
Mhm.
And that's been the most common thing that I've done with ketamine. I've also referred people for ketamine assisted psychotherapy. So sometimes I
Mhm.
prescribe the sublingual tabs for use in with a trained therapist in a
Mm.
90-minute psychotherapy session to help people, and I think it turns off the left brain so that the right brain can tell you important things and make
Mhm.
connections. So that I prescribe it for that. I don't have too much experience prescribing it for, are you talking about prescribing it for daily home use?
Yeah, when
Uh-huh.
I prescribe it, I'm prescribing it for pain, for
For pain.
persistent pain, and
Mhm.
I'm aiming for, taking the edge off the pain without the psychoactive, or with minimal psychoactive effects.
Mhm.
And especially for people that have a lot of central sensitization, or maybe they're
Mhm.
coming off opioids or something like that. I was just curious if you prescribed it, recommended it. There's obviously, like you just said, there's IV and there's all, different ways to administer it. But I was just curious what your thoughts were.
Yeah, I'm usually prescribing it more for depression in those big doses, and I refer people, to someone who I think does also prescribe it more for daily use for certain conditions, but I'm not usually prescribing for pain. But
Mhm.
that's interesting. What dose do you usually find is the dose that helps with take the edge off the pain without being psychoactive? Is that 25
So
or 50, or is it
so yeah, so I write for 25 for their
uh-huh,
first script, and I say take a half to a whole,
uh-huh.
and I tell them, like, we're looking for just, another tool to have in your toolbox to, you know, give you a little more reassurance that if things are bad, that you have something that you can do. And then, some people say, well, if I take 25, it really seems to help. And then if they do that, then usually I'll write the next script for 50. So that way they can take a half because then it's less expensive since it has to be compounded. So then I'll say, still take a half. We're looking for like the lowest effective dose,
Mhm.
which, I did have a patient once. He's tall guy, really, really big guy. And, he did not take it as I prescribed it. He took he took one and then a few minutes later took another one. And he took like 6 total. So he took 150 milligrams, and he said he didn't feel anything at all. But he had some psychoactive effects. So I have patients who, are not able to find that sweet spot. And then I have other people who are like, you know what? I take my 25 milligrams at night and it just helps me, kind of relax, and I know that I have it there, that I can use it if I need to, and, they don't escalate the dose. We're just staying at that same dose, and, so I know it's really low, but I'm usually hoping to have that low dose to, keep them out of, ketamine cystitis, which is obviously, we're nobody knows what the magic dose is for that, but we're, way, way below that, of course. Yeah.
Yeah, I think I've heard of a compounding pharmacist who really believes in using low-dose ketamine for depression. Have you seen antidepressant effects at that dosing?
That's a great question because, of course, if you're making the pain better, then, oftentimes they're sleeping better and the depression is better. So
Sure.
I should start asking that more specifically. When you're doing the sublingual ketamine and they're doing the psychotherapy, I love that. And I'm assuming that these are people who, that's maybe their niche. If for the average, adult, what kind of dose would you be looking at for that?
Usually I prescribe the 100 milligram
Mhm.
dissolving tabs, and I'll have them work together with the therapist to find the right dose.
Mm.
It's usually about 250, I would say, is the average dose for that. And
Okay.
we're looking for a dose where there is some, sedating effect, where they get that kind of dissociative experience.
Yep.
So
Yep.
that's what kind of uh, unplugs the left brain so the right brain can talk.
Mhm.
And so it's usually about 250, but it might be between 200 and 300, something like that. I have
Mm.
had occasionally people say, oh no, it takes 400 or it takes 450, but that's the outlier. Yeah.
Mhm. Mhm.
Mhm.
Yeah, and I have a patient she's young and takes 175 milligrams like every night. That's her dose she gets from a psychiatrist, and she takes
Mhm.
that every night. And then I have other patients who are usually it is, I feel like a psychiatrist that's prescribing 500 milligrams, and I think they're taking it at home. So, yeah, it's very interesting how that medication is used in so many different ways.
Yeah.
So yeah, interesting.
Mhm.
Okay. Are there certain psychiatric medications or treatment strategies that you find to be most problematic or potentially harmful for people with mast cell activation?
I don't think so.
Okay.
I guess the thing that comes to mind is the issue about excipients,
Mhm.
and people having their mast cells flared by excipients and medications. But I don't have a sense of certain psychiatric treatments or medications that need to be avoided in
Okay.
people with mast cell activation. It's more about paying attention to the individual sensitivity. And I think, especially if somebody comes in and they don't know anything yet about mast cell activation, that can be a very confusing time, right? It seems like
Mhm.
everything is making them worse. You're like,
Right.
I don't tolerate this. I don't tolerate that. That's was not helping, not helping, not helping. And I'm like, okay. Before I knew as much about mast cell activation, you could run yourself through 12 different meds and,
Mhm.
nothing has helped. And, you feel terrible. You haven't helped the person. But now I know more to slow it down and really lean into the chromalin I didn't mention before, the
Mhm.
H1 blockers, H2 blockers, and really lean into that because if somebody has mast cell activation, the thing that really helps is to turn the baseline down so that
Mhm.
then people can see their dips or their flares, whatever they're called, right? They can see
Right.
their dips, and it's not all buried in white noise. And then once that baseline is turned down, well, first of all, we can reassess the psychiatric symptoms and see, is there anything left to treat? Sometimes there's not. Sometimes, Cromolyn, Benadryl, you're like, "Oh, thank you. I'm done." You know,
Wow.
it's amazing.
That's awesome. Yeah.
Yeah, but other times then, there's more room, there's less noise, there's more room to then use, whatever it's gonna be.
Mhm.
I was gonna say, an SSRI. I would say, and maybe you got this already, but I would say, I lean more toward lamotrigine and lithium in this group.
Mm.
I would say the mood symptoms that people tend to present with, they look like bipolar-ish types of symptoms. I hope they change the DSM in my lifetime. So we have some better labels for things, but so I say bipolar-ish because looks like bipolar, probably responds to meds for bipolar. Do I really think it's bipolar? No, I really think it's mast cell activation. But anyway, I do think it's not uncommon for people who have mast cell activation in my practice that they don't respond as well to SSRIs, and they do respond better to lamotrigine and lithium, which are both just antidepressants. I mean, and they're mood stabilizers and they're anti-anxiety. And so I say, well, we're just using this non-specifically. We don't need to put a label on this. But, it can make people uncomfortable. This idea, like, why are you recommending bipolar meds for me? I'm like, don't think about that. Let's just think about what helps.
Yeah, I know that's an interesting point about, the potential stigma of having, lithium, for example, in your records. Or I even thought about that. I take low dose naltrexone, and I even thought about that before I started low dose naltrexone. Are people going to look at that? And, I mean, I've had people say that when I've suggested to start them on low dose naltrexone, and I don't really think about it anymore for myself. But when they ask me that, I of course talk to them about that, and hopefully a lot more people are aware of, the uses of that off label, for chronic pain and things like that. So, but yeah, it's tricky. What about lithium low dose for cognitive function? Do you ever recommend that?
All the time. All the
Really?
time. Yeah, I do. I love lithium orotate in doses between, 5 milligrams and 20 milligrams. Well, I use it in a couple different scenarios. I might even use it for insomnia or irritability or mood swings. If someone's got, a subtle kind of mood swings or low mood, a depressed mood, I'll have them try a week each of 5, 10, 15, and 20 milligrams of lithium orotate at bedtime, and then compare and contrast, see which week do you like the best and stay on that dose. If somebody has a more robust kind of a bipolar picture, and they would like to replace prescription lithium with lithium orotate, then I might have them use 30 or 60 milligrams of lithium orotate. But you're asking about cognitive function. I think the data is pretty good. And then even the new stuff that's just come out about lithium and possibility of dementia prevention is exciting. So everybody who comes in and says, I'm worried about dementia, I'm worried about my cognition, I'm like, well, this is safe and easy. Just take 5 milligrams of lithium orotate, and you don't have to follow levels. If you tried to check a blood level, it would be undetectable.
Right.
It doesn't carry the same risks as a prescription lithium for the kidneys and the thyroid. So I think it's kind of I don't want to call it a no-brainer, because what we want is a full brainer.
Right. Yeah, absolutely. This has been such a great conversation. I have so many other questions I want to ask you, but I'm gonna try to wrap up and see if I can just fit a couple of more things in here. One is, what are the non-pharmacologic things that you find most helpful in this population? Are there certain things that you think are, really important for people to incorporate?
Yes, I think, some people respond to the low histamine diet. And so I do usually have people try that. Some people it makes no difference. And so I think, well, they must have a different population of mast cells in a different part of their body. They're not, they're not the people who get the flushing after meals and tachycardia after meals. So I have people try the low histamine diet and then decide if it helps them or not. I think stress management and sleep hygiene and awareness about triggers, so that you can be proactive and you can be prepared and you have your kit with you, and, those kinds of things. As people mature further into their course of mast cell activation, I think people get better at that, and that can improve their quality of life. I think psychotherapy to help address the kind of the stubborn emotional buttons
Mm.
that can get people riled up. Because if your buttons get pushed, then your mast cells are getting pushed.
Mhm.
And so I think understanding your buttons more and finding, compassion and healing for your inner buttons is an important step. I'm a huge fan of internal family systems therapy. I don't
Mhm.
offer it myself, but I'll give a shout out to IFS
Mhm.
because I think it's one of the fastest psychotherapy techniques I've ever come across in 30
Mm.
years. And the people who do somatic IFS, and those people are listed on Susan McConnell's website, um, which I think is called embodiedself.net, but I might be wrong. She treats different parts of the body as different parts of the self. So you can actually
Mm.
have a dialogue between your own higher self and, say, your mast cells, and say, okay, mast cells, what are you? What do you want me to know? What are you doing for me? How are you helping me? How are you protecting me? The idea is that every part of your body is doing a thing that it has learned to do, thinking that it's helping you or responding, to something. And I think I think that can be really powerful. That's really
Mm.
exciting. Yeah.
Mhm. Mhm.
Mhm.
Well, that's really cool, and I know that you have a new business offering, so if you could tell us about that and where people can learn more about you, and if you have any other projects going on.
Yes, the new thing that I'm launching is a medical intuitive reading practice. I got certified by uh, a certification group led by Wendy Coulter called The Practical Path as a certified medical intuitive. And so, what I do in those readings is connect with the person's higher self in order to read an energetic representation of the physical body.
Mm.
And I believe that we all have um, traumas. They might be individual traumas or even collective traumas or lineage, ancestral traumas, beliefs, emotions, things that are stuck in the energy body, right? I mean, everybody is made up of an energy body and the physical, which is the scaffolding, and the physical body is sort of, organized around that scaffolding of the energy body. And so there are you can look into the kidney, or you can look into the mast cells, or you can look into the brain and see what's going on in there on an energetic level. Is there some stuck, hidden trauma that came down the family line, or, from earlier in life? And it really can give people such a nice sense of either validation, like, oh, yeah, I knew that was it, or, direction, like, "Oh, I didn't realize that was it. Let me go after that thing." And, the reading includes recommendations for things to do on the physical level, and maybe also on the energetic or emotional level, about how to address these issues that might be underlying physical conditions. And so it's really fun. I'm really excited about it. I'm launching a new website. It's not quite up yet, but it's the business is called Gateway to Healing with the number 2. It's gateway2healing.com, and it should be up in about the next month. So I'm excited to add that to what I'm doing, because you were asking about other things people can do, and I think everybody has their own comfort level with this, but I believe that spiritual healing and finding a connection with one's own higher self, or any connection at all that a person feels comfortable with with the universe, or with the divine, or with Mother Earth, whatever you want to call it,
Mhm.
is really so healing. It can be healing literally in terms of the body, but it can also be healing in terms of hope and context and resilience and not feeling alone.
Mhm.
One of the uh, things that's really been a motivation for me on this long journey is gradually seeing more and more and more of how people appear to be fairly betrayed by the medical system, that
Mhm.
I
Mhm.
joined and trained in and pledged myself to and have worked in for all these decades. And so I think that feeling of loneliness and medical trauma that comes from being dismissed and devalued and kicked out of ERs and,
Mhm.
eye rolling and all of that stuff can come from this stigma of having psychiatric meds and psychiatric diagnoses on your chart. But I think it's almost even worse for people who have chronic fatiguing illnesses, in this cluster of things that includes mast cell and EDS and POTS. And um, so that's tragic. And I think that there's some real healing to be found in, finding a connection not only with the peers, and other people around you, but with whatever spiritual resources you feel comfortable accessing. So,
Mm.
yeah.
Mhm. I love that. That's really cool. And you may know that we always finish every episode with a hypermobility hack. Do you have a hack to share with us?
Yes, the hack is don't stop looking for the deeper root causes because there's so much research going on right now into new things. Don't, if people tell you, like, oh, you just have this and done, case closed, you just have to live with it. I disagree 100%. I think
Mhm.
keep learning and keep looking because there's new stuff coming out every day, like about the dental cavitations. Like, talk to me again in a year about the parasites, about heavy metals you mentioned. There's so much on the horizon that I think is beyond even calming the mast cells that's going to address the deeper level. It's like, don't forget that there's lots more coming down the pipeline. And I think that there's more openness. I hope there's more openness, or else I'm living in my own bubble.
No, I definitely think that there is, and that's why I, really started getting more into, educating people about pain long before I had, like, the podcast and everything, because I would go to conferences, I would go to anesthesia conferences and, go to lectures about pain, and it felt like there was such a disconnect between, researchers sharing different things that they're doing, and then people thinking, well, there is nothing. And of course, part of the problem is the amount of time that it takes for information to come from the bench to the bedside, which is a huge part of the problem, which you could talk about that for a long time. But,
Mhm.
we need to work on that, of course. But I think it's really important for people to be aware that, there are people that are working on these kind of things. And so I think this is making me feel really hopeful because psychiatric problems are really pervasive. And so many people I feel like are, suffering and really struggling. So this was really, really helpful. And I'm so
Good.
grateful to you for taking the time to chat with me today.
Thank you so much for having me. It's been really fun to connect about this and to share information that I hope will be helpful for people.
Well, I really enjoyed that conversation with Dr. Settle. I feel like these psychiatric problems are just so difficult to navigate sometimes, and it gives me a lot of hope to think about all of the possible stones that we can unturn and really try to find the root causes of a lot of these symptoms. So thank you so much for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. I hope you will check out my other resources, including my newsletter, The Bendy Bulletin. You can check that out on Substack at hypermobilitymd.substack.com. You can help us spread the word about joint hypermobility and connective tissue disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex conditions. Did you know that I also offer one-on-one support for both clients and healthcare professionals? Whether you're living with a connective tissue disorder or caring for people who are, I've got your back. Check out my coaching and mentorship options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at hypermobilitymd. You can find Human Content, my amazing producing team, at Human Content Pods on TikTok and Instagram. You can also find full video episodes up every week on YouTube at Bendy Bodies Podcast. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements shared on Bendy Bodies should be considered medical advice. Please always consult with a qualified healthcare professional for your own care. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a human content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.